Thank you very much. I'll start at once with the talk, and I will say a few words, bad words about Steve later. Okay, so what are the determinants of remission and cure for such long-lasting disease? You know, it can last more than 20 or 30 years, sometimes a lifetime. So it is very important, as early as possible, to determine what is remission, is it possible or not, and can we be cured? So that's the reason why we're going to go through very quickly the definitions of remission, complete, on or off treatment, a cure or criteria. I'm sorry, those are my, may I put my, this is the old talk, I changed everything. I was in Hamburg and I had a lot of beer and realized that I made a lot of mistakes. I gave that talk 20 years ago. Can you recognize it, Steve? By the way, I published it in an obscure journal because Steve rejected it.
Which one is it?
Final somewhere. Final here.
Here?
Yeah.
Or final two?
Final two. Thank you.
Yeah, no problem. Thank you.
The colors are better. Okay. So, as it has been said several times this morning, the course is quite bad despite multiple treatments and sometimes very toxic treatments. And a remission is written here. I'm not going to tell you what is a remission, but it can be complete or partial. And that will be very difficult to distinguish between a partial and a complete remission. And as Carl Herbert just told you, there are several components, and Hank Kaplan also, several components to the disease, and we're going to talk about that later. The Sun criteria are bad criteria to talk about remission. The Sun criteria talks about 3 months of inactive disease. And as you know, 3 months is not enough to talk about remission. So we need at least, we think, we don't know yet, and maybe a multiple center study will tell us, at least 6 months, but better 1 to 2 years without any active disease before even talking about remission. It can be complete remission or also durable remission. A cure is the end of the disease. And, but even if you think it's cured, there can be exacerbations that are completely unpredictable. And that's the reason why some people talk about a cure rate, a 5-year cure rate. 20%, and Dr. Foster's group have shown that if you give an appropriate treatment, a sustained treatment, you can be cured. And you need at least 2 to 5 years of intensive, aggressive, close monitoring to be able to get cured. And 27% of those patients are cured. We can talk about a 5-year, 27% cure. So the title of the talk, in the present, we should ask 2 questions. What are the criteria to talk about remission or cure? And what can determine the occurrence of a worsening or improving of the disease or remission? So, of course, we are unable to answer those questions, but I will try with you to approach some ideas. Definition of remission, difficult to say. As it was said this morning, all those talks said, how can we be certain that there is no more creeping intraocular inflammation going on? And a lot of the patients, even though they have a very, very good visual acuity, they feel symptoms, photopsia, night blindness, and that are worsening with time. So this is a common sense definition. But as it was stressed this morning, there are indirect signs, and you've got to, of course, pay attention to visual fields and ERGs, as it was said, and for 100 times, visual acuity is not a good, reliable indicator. It's even worse with partial remission. What should I say? The most obvious is patients without any dark spots on the ICG, but even though the retinal disease is still going on, as Herbert was saying. Indeed, there are at least 3 components to the disease: a choroidal disease, a retinal disease, and as Hank said, an outer and an inner retinal disease. The optic nerve also, which is close to the inner retina. Each of the 3 can evolve independently of the 2 others. That's the reason why it is so difficult to talk about remission, complete remission, and partial remission. So you should also not confuse a cure and an end-stage disease. Some people say, I'm cured, but they don't see anything. So it's very important also to monitor very closely all those patients every 4-6 months at least. And as Hank said, even though there is no clinical exacerbation, to ask for a systematic checkup of all those exams. So we're going to skip this slide and skip this one too, because you've heard a lot about those this morning. And here from the literature are the determinants for future remission or cure. As you can read early treatment, early IMT, minor EOG alterations, a good or not too bad 30 Hertz flicker implicit time, not too much delay, stabilization or improvement of visual fields, retinal architecture, and all those clinical are not reliable indicators for the functional dysfunction, retinal dysfunction. We have begun a very small preliminary study in Petit-Salpêtrière with Christine Fardeau, Baram, and one of the residents and the electrophysiologists. And among those 56 patients that we followed for several years, we had those numbers. And you can see that even though we were very keen on monitoring those patients, 15 of them were worsening despite what we thought was an inappropriate treatment. And the factors associated with the deterioration of the visual functions are listed here. It is very important, of course, to see that the history of autoimmune conditions, of course, we have very few cases. We're going to retrieve more files during the next few months. But the history of autoimmune and cardiovascular, I think it is because those past medical history problems prevent us from using even more aggressive treatment, and not because the condition is inducing a bad prognosis. And initial retinal vasculitis, that was already described in the literature, is a bad sign. As you can see here, it is statistically significant. It's much higher in the bad prognosis group. The treatment also, if the treatment is initiated early, the prognosis is better. When it is introduced later, it seems that the prognosis is less good, although we have not enough number to be statistically significant. The factors associated in the small series that is initial vitritis. This can be provocative and paradoxical, but in fact, because the doctor sees a lot of cells into the vitreous cavity, he tends to give a more aggressive treatment. Same with CME or CMO at the initial stages. When you see CMO, you tend to give even more aggressive treatment. So all those are listed here. I'm going to skip on the choroidal spurs, also fluorescein leakage at initial angiograms, and very low maximal amplitude of the ERG. So we have adopted what Dr. Foster's group has been recommended for several years. And I thank you very much having just mentioned the paper that we have published 25 years ago, because we had very bad results with conventional treatment, conventional IMT. That's the reason why we used at that time cyclosporine. So we need at least, 2 years of quiescence before tapering the medications. All the medications can be used, and others to come, and Bahram is going to talk about that. Corticosteroids is a misleading security, and a durable remission can be obtained. Those 2 papers are coming here from Boston, and here they are. So as I told you, if you give an MT for at least 2 to 5 years, you can have a 20% cure rate between 2 and 5 years of remission. And in 18%, they were in remission more than 5 years. In the other paper, which is in Arvo abstract, 27% had a durable remission of any treatment. So the patients can be cured. This is good news, and it's very new because we didn't know that. So in conclusion, we need an early diagnosis with what was said this morning. All the ancillary testing are very important. We need a very close monitoring with a lot of criteria, and we will not rely on clinical signs. The clinical judgment is bad. Oh, judgment, thou fled the British beasts, men have lost their reason. Julius Caesar, Shakespeare. Okay, thank you to all my collaborators, and thank you for your patience. I just want to thank Professor Foster for having me, having invited us, all of us, the patients and the doctors, to this second conference. And as usual, we should commend Steve for what he has done and is still doing, not only for the educations of our colleagues, younger colleagues, but also for the patients. He has always been very concerned about his patients, as we are all of us here, the colleagues coming from all over the world. Can I ask a big hand to commend Professor Foster?